Good morning, everybody, and welcome to the Neurosciences Grand Rounds. There is no commercial support for today's program. The planners and speaker have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. A link to the evaluation will be shared at the end of the program, and also in the chat if you are on Zoom this morning. And now it is my pleasure to introduce our guest speaker this morning. Dr. Luis Sanchez Iglesias is a provider with Northeast Georgia Physicians Group. Dr. Sanchez Iglesias received his medical degree from the University of Medicine and Health Sciences. He then went on to complete residency at Mercy Health, followed by a fellowship in clinical neurophysiology at Ohio State University, and he is board certified in neurology. Please join me in welcoming Dr. Sanchez Iglesias.
So good morning. As you said, my name is Dr. Luis Sanchez Iglesias. I'm one of the outpatient neurologists in the Medical Park 1, and I'm gonna be presenting a little bit of headache management, a little bit of information kind of like for the ED and kind of like the outpatient providers and everything. So we start for disclosure. I think there's nothing to disclose at this time. Some of the learning objectives will be recognize, different types of the headaches and learn a little bit of the workup and management for those specific headaches. And some of the topics we're gonna be seeing is type of headaches, the ED evaluation and office evaluation for them. So headaches in general, they're a pain or ache in any part of the head. And it's the most common reason to seek medical help, and the rival is basically backache when that happens. Headaches relies very heavily on patient's history, and this is kind of like one of the things that we do kind of like in medical school and our residency, like the ALLCARDS acronym for like onset, location, character, duration, character, associated symptoms, alleviating, aggravating, radiating, timing, severity, for those. And headaches can be divided into primary headaches or secondary headaches. And we use most of our time like the International Classification of Headache Disorder, which give us kind of like the criterion definition for these headaches to categorize them in their specific components. And common primary headaches are migraine, tension, trigeminal autonomic cephalgias that encompass basically cluster headaches, paroxysmal hemicrania, sungsuna, and hemicrania continua. Those are kind of like the more common primary headaches. And these are secondary headaches like idiopathic intracranial hypertension, post-trauma, infection, structural issues, trigeminal neuralgia, exertional cough, sexual activity, metabolic causes, sinus, cervical or occipital headaches, temporal arteritis, TMJ, and catamenial headaches. So this is one of the things that we use with the international classification. So migraines, we need at least 5 attacks, fulfilling criteria B to D, which is the headache should last, at least like 4 to 72 hours, and headaches at least with 2 of the following 4 characteristics, which is unilateral location, pulsating quality, moderate to severe intensity, or aggravated by physical activity, walking. That's where the ALLCARD kind of comes into play to get like the whole characteristics. And during the headache, at least 1 of the following, which is nausea or vomiting, or photophobia and phonophobia. When we have that with 5 of the attacks, then we say, hey, this is our very migraine in characteristics. Then we have types of headaches. Migraines without aura, with aura, hemiplegic complex migraine, which is a type of migraine with aura, which it consists of fully reversible motor weakness or reversible visual, sensory, or speech language symptoms. Retinal migraine is another type of aura, more like visual. Reversible monocular positive or negative visual phenomena, like scintillations. It's kind of like what they describe as a fortification, or kind of like the scotoma and blindness. And then chronic migraines. And then the chronic migraines, this is the criteria for it. At least 15 headaches a month for more than 3 months, and 8 of those 15 headaches should be migraine in characteristics. Once you have that, then you have like the diagnosis of like chronic migraine. The aura, the characteristic is basically one or more of the following: reversible, could be visual, sensory, speech, language. Sometimes this type of like auras are the ones that when they go to the hospital, sometimes they may be confused with like strokes and everything. We need to kind of like to do that distinction between them. And 3 of the following 6, like gradually spreading, 2 or more in succession, lasting 5 to 60 minutes, unilateral, positive. Those are the type of characteristics. We have tension headaches. These are at least 10 episodes of headaches lasting 30 minutes to 7 days. Bilateral location, pressing, tightening, mild to moderate, not aggravated by physical activity, and they don't have nausea, vomiting, and no photophobia, no more than one of the photophobia or phonophobia. So it's a little bit different from that, but it's the same. We had to kind of like look at the characteristics and put them in context. Then we had the tags, which cluster, it will be one. I'm gonna move a little bit here to this one. So basically, all these are the tags: clusters, paroxysmal hemicrania, Sung-Suna, and hemicrania continua. All 4, they're in the trigeminal autonomic cephalgia type of characteristic, and they have kind of like the same quality in terms of like being very sharp, stabbing, throbbing, the severance. The only thing that changed kind of like in between them is the frequency. Cluster will be 1 to 8 attacks per day. 5 to 50 will be paroxysmal hemicrania. 1 to 100 Sung-Suna, and constant hemicrania continua. And the duration, they all like different durations. At the same time, the treatment will be a little bit different between them in terms of oxygen, subcutaneous sumatriptan, or indomethacin, but we'll go through that a little bit later. But basically, they're kind of like in the same group, and they get a little bit confusion because we need to get a little bit more history in terms of like timing, frequency, and all this. We had the trigeminal neuralgia. These are recurrent paroxysms of unilateral phase pain in the distribution of more divisions of the trigeminal nerve. So the trigeminal nerve has 3 divisions: V1, V2, V3 in different areas. The more common being kind of like the V2, V3 area. And they describe it as having this severe intensity, electric-like shooting, stabbing, sharp pain quality. That is just kind of like a couple of seconds or a couple of minutes in a specific area. And it's precipitated also with air, sometimes by touching, sometimes by razor blade or anything. It can happen. We have IIH, or idiopathic intracranial hypertension. This has been diagnosed more with headaches that has papilledema or pulsatile tinnitus. So patients will come in, they will feel like, hey, they have like this pressure, the pain, vision, a little bit of disturbance or vision loss. When they normally see more commonly the ophthalmology first, and then when they evaluate kind of like inside the eye, they're like, hey, there's swelling behind both eyes. I think this, idiopathic intracranial hypertension. They come to the hospital. Basically, we do an imaging before doing the lumbar puncture. But if we have a pressure, more than 25 centimeters of water with this characteristics, it's like, hey, most likely this is idiopathic intracranial hypertension. Temporal arteritis is another one that goes a lot, in the hospital. Basically, this is headache, most related kind of like to the temporal area of the head. And mostly we see this on patients maybe like above 50 or 60 years old. And the most common concern for that is visual loss associated with tenderness of the scalp and jaw claudication. Basically, when they chew a lot, they will say, hey, I have like this pain there. And in the ED, for some of these headaches, we need to get, a good history, from that, kind of like to differentiate all these different types of headaches, get a good physical exam, making sure if there's any like, focal deficit, kind of like to compare for the strokes. Or if we're able to see a little bit inside the eye for that papilledema. I know it's a little bit limited because of the small, that we have, the ophthalmoscope, but we can do that. And then we can do, some head imaging, making sure there's rule out any bleeding, tumors, depending on the exam that we do. And then we check for lab work too, making sure there's no metabolic issues, infections that is causing this type of headaches. And then lumbar puncture if the IIH is suspected, or any infection if there's meningitis causing a secondary headache. Imaging for IIH, you need to make sure there's nothing going on before the LP, just to make sure there's no herniation of the brain. LP should be above 250 millimeters of water or 25 centimeters of water. And the management basically is with neuro-ophthalmology. Weight loss is very common, kind of like in these patients, avoiding of vitamin A products. And for therapy, these are the two more common medications that we use. Acetazolamide is kind of like the primary that we use, 500 milligrams twice a day. And we can start low, like maybe 500 daily for a week until we reach 500 milligrams twice a day. I do it more slowly, kind of like to avoid having more of the side effects for the patient, so they're able to tolerate a little bit better. But we can do Topamax or loop diuretics. Other type of management, if it doesn't work, then it's basically working with or neuro-ophthalmology or neurosurgery, because at some point, if patient is unable to take these medications or any side effects, they can consider like a shunt or fenestration of the optic nerve. Temporal arteritis. So in the hospital, when they come in, we'll do some imaging, making sure there's no other type of vasculitis going on. CVC set rate and CRP set rate if above 55, and sometimes we do also a temporal biopsy. And the management for this is basically the steroids, typically 3 days of high dose IV prednisolone, 1,000 milligrams per day, or equivalent to before switching to the oral. For that, basically what we're trying to avoid is vision loss on these patients. Other ED reasons, it could be after a concussion, post-trauma, subarachnoid hemorrhage, stroke, infections, and didn't need imaging depending on the findings. And pain medication, there's surgery evaluation if it's a bleeding, or antibiotics if there's any infections going on. For the outpatient migraine, we have medications that we use for the acute and the preventive. For the acute, we have the triptans, these are sumatriptan, elatriptan, frobatriptan, sumatriptan, NSAIDs, could be any of the ibuprofen, naproxen, antiemetics we can use steroids, and the HE too. For preventive, these are the medications that we use first, the first three. So we have different families of different medications that we can use for migraine. And these can also be used kind of in the same for tension headaches. Antidepressants, we have amitriptyline, venlafaxine are some of them. If somebody comes in and they have the migraine and they're already in another type of antidepressant, we can count that as being on an antidepressant, even though they're not kind of the classic ones that we use, like amitriptyline and venlafaxine. Sometimes they come in and they have sertraline or any other medication. We can say, hey, patient already tried this type of medication. Antihypertensive is another type of family that we use for migraines. Could be propranolol, timolol, verapamil, etc. Anti-seizure medications like Topamax. Other patients, sometimes they're in gabapentin. We can kind of use that also as a medication that says, hey, for on the anti-seizure medication for migraines. And then when patients try already 2 medications of 2 different families, then we kind of use these medications here. It's the CGRP, which are kind of the newer ones, Emgality, Anjovi, Aimovig. These are injectable medications that are given monthly. Qulipta is another one. This is given daily. And then we have the Botox. This is for chronic migraines. So when we have that characteristic of having more than 15 headaches, more than 8 of them be migraines for more than 3 months, patients can then be seen by a neurologist to do the Botox therapy. So as needed, triptans, you can take 1 tab, you can take another one in 2 or 4 hours, but If no good result, no more than 3 tablets in a week. We want them kind of like to not overuse them too. Sumatriptan, these are kind of like the normal 25, 50, well, not 200, 100. Sorry, this was an error here. Elatriptan could be 20 or 40, rizatriptan 5 to 10. Normally when patients are like naive that they haven't tried any of the triptans, we start like with the lowest dose, and then we can start like going up. If they say, hey, I started with 25, I took us another one and kind of like helped better, then we can switch instead of like 25 and take it twice, you can then switch it to like a 50 to altogether. NSAIDs, naproxen, Toradol, ibuprofen, and then Zofran too. We can use this type of medications. For preventive, these are kind of like the usual doses. Amitriptyline, 10 milligrams, we can start the same thing, kind of like start low, kind of like to make sure no side effects on them. And then we can go, sometimes I do like 10 for like a week or two, and then we go to 25. But it can go up to like 125 milligrams. The thing is that if it's like, hey, we're already like on 100 and still not doing anything, side effects, and it's just kind of like take it out. Venlafaxine, 37.5. Topamax from 25 nightly or twice a day to make it like 50, or we can go to like 50, kind of like a total of like 100 too. And the same thing, we can start like low and kind of like go up. Gabapentin, the same thing, and propranolol, like we can start like at 10 daily, then twice a day, up to like 40 twice a day, and we can do the same thing. We just have to make sure in terms of like side effects that they don't have. For example, for Topamax, making sure there's no history of kidney stones. Patients can get tingling in the fingers. Some cognitive dysfunction can happen with the Topamax. For the propranolol, making sure there's no asthma on those patients, but we can try any of these for the patients. And we can use also, if the patient is having a particular diagnosis, let's say seizures, so they can use kind of like the Topamax at the seizure at the same time, like one medication to treat two things. Or if they have like some anxiety, then we can use, for the amitriptyline venlafaxine, since it's an antidepressant. The same thing with the propranolol. If it's like, hey, a little bit of blood pressure here, let's try to use it to treat two things. Once the patient tried 2 medications of different families for a good amount, maybe 6 to 8 weeks, or if side effects occur, then we can do other therapies like Emgality, Ajovy, or Aimovig, which is one of the things that insurances will ask, like, hey, does the patient try, and we have to like document like, hey, patient tried this one, 8 weeks, didn't do anything, or has any side effects, then we can do any of these. And Emgality is the only one that needs a loading dose. So in the first month when you give it, it should be 2 injections in the first month and then 1 thereafter. For the other ones, it's just 1. Qulipta, 60, and for chronic migraines, it's Botox every 3 months. These are the newer also of the as needed, like the triptans. If patient is unable to use triptans because of stroke, heart issues, uncontrolled hypertension, or side effects of taking the triptans, then we can use the Nurtec, Ubrelvy, or the Saspred. The Saspred is the newer one, also like it's a nasal spray. Sometimes we use a bridge therapy, kind of like when the patient comes in and they have like this continuous headache, kind of like a status migrainosis of having like the migraine continuous for more than 4 or 5 days altogether. While we give them the preventive, while we give them the as needed with the triptans, we do a bridge therapy that sometimes we can give, instead of like as needed, we can give them like for a couple of days, like a very scheduled dose of like a Toradol, naproxen, and sometimes like a prednisone, kind of like taper. Sometimes what we do in the office is we give them like a injection with like some Toradol, with Zofran, with the steroid, kind of like there, and then they can continue this for a couple of days to see if we're able to break the headache. For the TACs, which was the cluster, the sung, the paroxysmal hemicrania, these have a little bit other type of like therapy. So if we know it's like a cluster, these are the ones that we use kind of like for preventative. So we can use verapamil 123 times a day, or we can use Emgality, the 300 milligram formulation monthly. We can do that. For acute, we can do in the hospital like subcutaneous sumatriptan. High flow oxygen is another one that we use, and this is kind of like the rates that we do there. Or they can do it also at home. I haven't had any like patients to give the oxygen, but I have seen that, they give like an actual order, kind of like for the oxygen to use at home. Nasal lidocaine or nasal sulmitriptan is also used, and they can do also like steroids or trigger point injections in the area where the cluster headache is there. For the Sungsuna, we can use IV lidocaine. This is more like in the hospital, we do like a week admission, contrary to clinical cardiac patients. And for preventive, we can do Lamictal and titrating, carbamazepine or duloxetine for these type of patients. For paroxysmal hemicrania and hemicrania continua, indomethacin is the medication that we use the most. This is a type of NSAID, but it's very responsive for these medications. So this is kind of like the one that I do, kind of like for a week. Basically 3 days, 6, and then 1 day of like taking 3 times a day for like a week. There are other type of like formulations, but this is the one that kind of like use a little bit more. Trigeminal neuralgia, like we were talking, this is the therapy. Carbamazepine is the first one kind of that we use, 200 milligrams twice a day, on up to like 600 milligrams twice a day. Oxcarbazepine is another one that we use. Sometimes we start the patient on this one, and in a couple of months we can switch to this one. Other patients says like, hey, when we should switch to this one, it didn't work as this one, so we kind of like keep this one later. And then Lamictal too can be used. Surgical evaluation can be evaluated if these medications are not working. When we do an MRI, we look at the facial nerve, at the trigeminal nerve, and we try to see if there's any like abnormal vessel there, so they can be evaluated by neurosurgery if they need to do any particular, therapy for that, like that abnormal artery. Occipital neuralgia, these are like the headaches, kind of like on the back of the head. Some patients will have this more common when they have a trauma, like a whiplash or anything there. Basically, the patient will say, hey, I have like this pain that starts here on the back. And when you press, the greater and the lesser occipital nerve, that's when they feel like, hey, the tenderness is there. Feels like it can move up or can move down when you press on them. And basically, what we're gonna be doing is a trigger point, basically a nerve block I do it more with lidocaine. Some physicians, they mix the lidocaine with the steroid. And this nerve is coming from C2, C3. So sometimes if the issue is there, sometimes we are able to calm it here. But with that particular therapy, some physical therapy for the neck, sometimes we get the patients with pain medicine, so they can evaluate more like deep in the neck. And sometimes they also able to do some other trigger points more on the neck muscles or the upper shoulder muscles. Kind of like the whole area here is the best therapy that they can get for that. And then other headache medications, these are the same that we talk, kind of like the naproxen total. DHE admission, sometimes there's a couple of patients that, they have like the migraines and they're still like remitting in terms of like a status migrainosis and everything. So some patients will able to send them to the hospital to do a DHE admission. Basically, this is a medication that is given almost like every 8 hours. For that, we need to make sure there's no like cardiac issues, for those patients, but we can keep them like maybe 1 or 2 days after they do this type of protocol. Depakote valproic acid can be used for 5 nights to see if we're able to break, the headaches. Olanzapine is another medication for like the headaches that are continuous, maybe 2.5 to 5 milligrams nightly. Nausea medication, antihistamine medications, and also in office and ED, some injections, like a combination of these, like an NSAID, steroid, nausea medication, and antihistamines, as much as the patient is able to do. I know when we have patients that, or they have side effects for steroids, or they are unable to take NSAIDs because of like the kidneys and all these different things, so we need to do different approaches. Any questions at this time?
Hey, thank you very much. So do we have, at NGHS, do we have any kind of like interventional sorts of things if somebody comes to see you in the office? Historically, I've seen, infusion capabilities or any of those kinds of things. Is that something that we do today or something that you think, something we could build on?
Yeah, I know for the infusions, we have a medication like the ones with the Emgality and Jovi, that it's the Vyepti, but that's more for like preventive. But in terms of like, when we did some admissions kind of like for DHE. I was trying to get a little bit more information if we're able to bring the patient to the hospital, because the infusion, like to give them, for example, sometimes we do a combination of magnesium along with the Depakote IV, hydration and everything. I think for the infusion that we have in the outpatient clinic, I think we don't have that. But when they go to the hospital, when they're admitted, kind of like for those things, I think it's one of the things that they do in the hospital, kind of like those cocktails, kind of like when they talk with the neurologist on call and they evaluate, the patients, those are the things that they're add on the overall therapy.
Right. Okay, thank you.
Do we have any other questions? Okay, Dr. Sanchez?
So I have the other 3 questions, but I don't know if you want me to do here or.
It's up to you if you want to engage with the audience and ask the questions, see if they've picked up those golden nuggets during the presentation.
Sure. Okay, so for example, this is, a question, 55-year-old woman with history of borderline hypertension, present to established care for migraines. She had occasional migraines for 20 years that has recently become more frequent. She now has 7 headaches per month with minimal benefits from acute medication. She has never tried a preventive medication before, and she's not on any medications. Her neurological exam is normal. Which of the following is the best option kind of like for her based on kind of like, seeing the migraine and everything?
Does anybody want to try to answer that one?
Okay.
What's it?
So we have amitriptyline as an antidepressant for migraine. We have candesartan as a blood pressure medication for migraine. We have Topamax as a anti-seizure medication for migraine. All 3 can be used as a preventative. Emgality is also used as a preventative, but patients should try something different before. And Nurtec is just as needed. I know there's a indication of Nurtec as for preventive. But for this patient, since she hasn't tried anything before, we can use all 3. Since patient has this borderline hypertension, we're like, well, needs 1, has hypertension. So using cardesartan as a blood pressure plus having the hypertension is kind of like the medication that we can use for her. Can you use, this is kind of like, using that reasoning for the high blood pressure and everything. But in other occasions, it's like, can we use any of the other 3? Sure. But in terms for like this one saying, hey, has hypertension and everything, never tried before, then we can use, the cardesartan. And then we have this other one, a 48-year-old man with no significant health medical history, present with 4 months of episodes of severe stabbing left eye pain associated with ipsilateral conjunctival injection, lacrimation, and ptosis. Attack lasts 12 minutes and occurred 10 times per day. Touching his face does not trigger the episode. MRI is normal. Which of the following medication is more appropriate for the patient? So doing this one is more understanding kind of like, the characteristics of the headache. Anybody? Okay, so for this one, amitriptyline is used more for like migraines, and this one doesn't, sound like they have like the migraine. Topamax is also another medication, kind of what we use with migraines, and it's not like a description for migraine. Then we have this 3, carbamazepine and lamotrigine are kind of like medications that we use for trigeminal neuralgia, but it says here, hey, touching the face doesn't trigger the episode. It's not described as a jolt, for that. And when we look at this is more as a trigeminal autonomic cephalgia, having like this severe stabbing left eye pain associated with that. And when the attacks is like 12 to 10, then we use basically indomethacin, basically paroxysmal hemicrania, because of the 12 minutes occurring 10 times a day with this criteria. And then the third one, 54-year-old female present with severe stabbing in her left mandible. Pain lasts few seconds and is triggered by brushing her teeth and chewing food. Pain episode lasts few seconds and occurred 20 times per day. She denies any recent trauma or dental procedures. Over-the-counter simple analgesics does not improve the pain. And on physical exam, touching the mandibular region produces the pain jolt-like. Neurological exam is normal. What is the most probable diagnosis with the pain jolt-like? And then we have trigeminal neuralgia, basically for that. Okay. And basically we use like the Cleveland Manual Headaches of Therapy and the AAN Continuum kind of for information and all this.
Thank you so much for your talk today.
Yeah.